I'm about to tell something that could save a life, and it's about a blood pressure number almost every doctor has called perfect. I'm Dr. Claire Whitmore, and after 2 decades as a cardiologist, I've treated thousands of seniors whose hearts, brains and kidneys were damaged, while a monitor in the exam room proudly flashed, "Excellent, 120 over 80." I have watched older adults fall, break hips and lose independence because everyone was chasing a number that looked beautiful on paper but was dangerous in a frail, aging body. By the end of this video, seniors will know 3 things very clearly. First, which blood pressure number has been oversold as ideal for adults over 60. Second, why that number can actually increase the risk of fainting, falls, strokes, and even dementia in many seniors. Third, a practical protocol to find a personal safe zone instead of mindlessly chasing 120 over 80. But that right range is not coming yet, because if the number appears in the first minute, many seniors will write it down, feel reassured and click away. That is exactly how strokes and broken hips happen, a number without understanding the why behind it. In a few minutes there will be a story about Patricia, an 81-year-old grandmother whose doctor smiled at a reading of 118 over 72 and said, "Perfect, this is exactly what the guidelines want." 3 weeks later, Patricia was on the floor with a brain bleed and a shattered hip. Before getting there, seniors can go to the comments and write 2 things. Age, the last blood pressure reading remembered, like 118/70 seconds or 142/86. Something simple such as 82/120 or 69/148/88. That real-world snapshot matters more than most realize. Patricia was 81 years old. A retired church secretary, widowed, living in a small brick bungalow. She kept her house neat, cooked simple meals, and used a walker outside but shuffled slowly around the house without it. She had 3 grown children and 6 grandchildren who adored her Sunday dinners. On paper, Patricia looked like a very typical senior. Her blood pressure had been in the 140s over high 70s for years on 2 medications. She had type 2 diabetes, reasonably controlled with a last A1C of 7.2%. She had moderate kidney disease with an estimated GFR around 42. There was a mild heart valve leak and some knee arthritis. She took 7 pills daily, 2 blood pressure drugs, metformin, a statin, a baby aspirin, and 2 arthritis medicines. For years, her longtime doctor had said, "Patricia, 142 over 78 is okay for age. Not ideal, but acceptable. Better than falling." Then that doctor retired. In January, Patricia met a new internist, younger and very guideline-focused. He looked at her chart, shook his head slightly and said, "Our newer recommendations suggest that top number should be closer to 120. It's better for the brain and kidneys." He mentioned the SPRINT trial and modern targets. Patricia did not follow every detail, but she heard one message clearly: pressure needs to be lower. "Doctor, won't that make me dizzy?" she asked. "Well, be careful," he replied, "but 120 over 80 has become our gold standard. Seniors do better when pressure is controlled more tightly." He increased the dose of one medication and added a 3rd small pill, calling it fine-tuning. Within 2 weeks, Patricia's office blood pressure was 126 over 74. "Beautiful," he said. "We're almost at target. Let's edge it a bit lower." He nudged a dose again. At the next visit, 4 weeks later, her blood pressure in the exam room was 118 over 70. He smiled broadly. "Perfect. This is exactly what the guidelines want." Patricia felt proud. At 81, she had a 20-year-old's blood pressure. She told her daughter, "The doctor says my numbers are perfect now." But numbers in a quiet exam room are not the full story. A few days after that perfect visit, Patricia began noticing that when standing up from her chair, the room went a little grey for a moment. She had to grab the armrest and wait. She mentioned it at a quick nurse visit. "Sometimes I get a head rush when I stand," she said. The nurse took a sitting blood pressure, 116 over 68. "Wonderful," the nurse said. "Older adults would love to have readings like these. Just stand more slowly." Patricia accepted that reassurance. After all, both doctor and nurse were thrilled with her 110-something over 70-something readings. Over the next 2 weeks, the dizziness worsened. Getting out of bed, she felt unsteady. In the kitchen, turning too quickly made vision blur for a second. Her daughter noticed Patricia was walking more slowly, holding onto furniture. "Mum, is everything all right?" her daughter asked. "I think it's just age," Patricia answered. "The doctor says my pressure is perfect." Then came the day everything changed. It was a Tuesday morning in March. At 7:15 a.m., Patricia woke, sat on the side of the bed and reached for the lamp. As she swung her feet to the floor, a wave of lightheadedness washed over her. She paused, waited for it to ease, then stood slowly. She shuffled toward the bathroom. Halfway there, her vision tunneled, dark at the edges with a roaring in the ears. Her heart felt like it slowed and then thumped irregularly. She grabbed the door frame, but her hands slipped. Her knees buckled. Patricia fell sideways, striking the right side of her head on the dresser before crashing to the floor. She did not get up. At 8:03 a.m., when she did not answer her daughter's usual call, concern grew. By 8:20, after 2 more unanswered calls, her daughter drove over, used her key and entered. "Mum?" she called. Silence. She found Patricia on the bedroom floor, on her side, blood matted in her hair, right leg twisted, breathing shallowly. Her eyes fluttered but did not focus. Her daughter dialed 911. Paramedics arrived at 8:32. They checked blood pressure while Patricia lay on the floor. 92/58. Heart rate 54, slow for her. Oxygen a bit low. Looks like a bad fall from a fainting spell, one paramedic said. Let's move fast. In the emergency department, a CT scan of the head showed a subdural hematoma, a blood collection on the surface of the brain on the right side where she had struck the dresser. An X-ray confirmed a displaced fracture of the right hip. Her daughter stared at the images. But her blood pressure was perfect, she said. 118/73 weeks ago. The doctor was so pleased. The trauma physician answered quietly, for an 81-year-old with kidney disease and 3 blood pressure medicines, 118/70 may have been too low. When she stood up, pressure probably dropped further. The brain did not get enough blood, she passed out, then the fall caused the bleed. Lab work added detail, sodium slightly low from dehydration. Kidney function worse, GFR down to 35. Hemoglobin normal enough for surgery. They reviewed her chart, 3 separate blood pressure medicines, including one taken at bedtime. In other words, her cardiovascular system had been pushed hard toward that ideal 120/80, without anyone checking what happened to pressure when she stood up. Surgery was needed to repair the hip. The brain bleed was borderline. Neurosurgery chose close monitoring rather than immediate operation. The hip operation was long. Blood pressure during anesthesia swung between 85/50 and 110/60, despite efforts to support it. Each low swing meant less blood flow to an already bruised brain. In the days that followed, Patricia was not the same. She was confused much of the time. Sometimes she knew her daughter, sometimes she believed she was back at work decades earlier. She could not get out of bed without 2 aids. Physical therapy was slow and painful. The independence she had at 81, cooking, walking to the mailbox, using a walker only outside, was gone. Her daughter asked one of the consulting geriatricians, "How did this happen?" She did what she was told. She got the blood pressure to where the doctor wanted. For some seniors, especially frailer ones, chasing 120/80 is too aggressive, the geriatrician said. The brain and heart still need enough pressure. When standing pressure drops too low, the risk of fainting and falling goes way up. Patricia survived, but she never returned to her little house. She needed long-term nursing care. Her memory and mobility stayed severely limited. Not from age alone, from a number 118/70. That sounded perfect, but was not perfect for her. Here is the disturbing part. This was preventable. If someone had checked blood pressure sitting and then standing, noticed a big drop, and accepted that a slightly higher number might be safer for Patricia, that fall might never have happened. At this point, it is worth a brief pause. Any senior who has ever felt lightheaded, grey-visioned, or as if fainting within a minute or two of standing from bed or a chair can type the word dizzy in the comments. That symptom is not just getting older, it is a classic sign that blood pressure may be dropping too low when upright, even if the sitting number looks perfect. Next, another quick check. Seniors can write 3 things together: age, usual blood pressure if known, how many blood pressure medications are taken. For example, 79, usually 118/70, 3 meds, or 72, 138/80 seconds, 1 med. The same number, say 120/70, has a very different meaning in a strong 68-year-old on 1 pill than in an 84-year-old on 3 pills with kidney disease. That difference is exactly what needs to be understood. Now, why is 120/80 not automatically the best target for every adult over 60? For decades, the mantra in medicine was simple. The lower the blood pressure, the better, and the magic number held up as ideal was 120/80. On posters and pamphlets, seniors saw the same chart. green at 120/80, yellow above that, red above 140/90. What almost no one explained clearly was that most of those charts were based on research in middle-aged adults, not in frail seniors in their 70s and 80s with stiff arteries and slower body responses. As the body ages, several things change in the circulation. Arteries that used to be soft and elastic become stiff and less responsive. The pressure sensors in the neck and chest baroreceptors become sluggish. The heart often develops some scarring and electrical quirks, making rhythm and pumping less forgiving. The brain may already have narrowings in small vessels and little areas of old damage. Think of blood pressure like the height of a water tower feeding a town. In a young adult, the pipes are smooth and wide. The tower can be lower and still deliver water to every house. In an older adult, the pipes are narrowed, kinked, and partially clogged with mineral deposits. If the tower is kept too low, water may not reach the houses at the top of the hill. The brain and kidneys, especially when demand suddenly rises, such as on standing. 4 key differences make seniors very distinct from younger adults when it comes to blood pressure. First, stiffer arteries mean bigger drops on standing. When someone stands up, blood momentarily shifts to the legs. The body is supposed to tighten arteries and speed the heart slightly to keep pressure stable. With stiff vessels and slower reflexes, this adjustment is late or weak. A sitting pressure of 120/70 can become 95/55 in seconds. For a brain with narrow vessels, that is not enough. Second, the brain's reserve is lower. Many adults over 60 already have some narrowing in arteries that feed the brain and a bit of small vessel disease. The brain in this setting needs steady, adequate pressure. Drop it too low, and there is dizziness, confusion, or a fall, even if complete fainting never occurs. Third, medication stack. Most seniors are not on a single gentle blood pressure pill. 2 or 3 are common, often plus diuretics and other drugs for prostate, Parkinson's, depression, that also lower pressure. When a clinician chases 120/80 in the clinic, there is a real risk of overshooting in day-to-day life, especially in early morning or at night. Fourth, frailty and mobility change the risk balance. For a strong 65-year-old who hikes, the main threat may still be strokes and heart attacks from pressure that is too high. For an 85-year-old who uses a walker, the biggest short-term threat may be falls, hip fractures, and head bleeds from pressure that is too low. Research has slowly caught up. The SPRINT trial, often quoted to justify lower targets, did show that in many adults, including a group aged 75 and older, aiming for a top number around 120 rather than 140 reduced strokes, heart attacks, and deaths. But several important details are often glossed over. Many very frail adults and nursing home residents were not included. Blood pressure in the study was measured under ideal, quiet conditions with repeated checks. Participants were monitored very closely for side effects. Even in that setting, more intensive treatment led to more episodes of low pressure, fainting, and kidney problems. Other analyses, including work published in JAMA, have shown something that surprises many. In frail older adults, especially those with multiple illnesses and limited life expectancy, very low blood pressure, especially a systolic under about 120, is sometimes associated with higher death rates, not lower. In other words, for some seniors, the curve is U-shaped. Very high pressures kill, very low pressures also harm. A large European study of adults over 80 found that those with systolic pressures in the 130s and low 140s sometimes did better than those pushed into the 110s, particularly when frailty was present. For years, the messages bounced back and forth: under 140/90 is fine. Then, no, under 130, even 120 is better. The truth for older adults is more nuanced. For many robust seniors in their 60s and early 70s, especially with diabetes or previous heart disease, bringing very high pressures, such as 160s and 170s, down into the 120s or 130s is clearly helpful. But for many frail seniors in their late 70s, 80s and beyond, especially those already on multiple blood pressure medications, pushing pressure all the way to 120/80 can be too much, particularly if dizziness, falls or confusion appear. The real problem is not that 120/80 is bad. It is that one universal number has been treated as sacred. Instead of asking a better question, what is the safest range for this specific older adult, in this specific body, with this specific level of frailty and medication burden? Now, how can that safer personal range be found? At this point, many seniors are thinking, so what should the goal be? 120, 130, 140? That is natural. A single neat target feels comforting. But for older adults, the more useful idea is not one exact number, but a safe range. To reach that, 3 ingredients are needed: accurate home measurements, readings taken both sitting and standing, a target range that accounts for age, frailty, and how many medications are involved. First, a reliable home monitor is essential. Decisions cannot be safely made on rushed clinic readings alone. The monitor should be an automatic upper arm cuff, not a wrist cuff, with the right cuff size for the arm. Validated brands can be suggested by clinicians or heart associations. Second, technique must be correct. For 1 week, seniors can avoid caffeine, smoking, or exercise in the 30 minutes before checking. Empty the bladder. Sit in a chair with back supported and feet flat, not crossed. Rest quietly for 5 minutes. Support the arm so the cuff is at heart level. Take 2 readings, 1 minute apart, and write both down. Do this in the morning before breakfast and pills, and in the evening before dinner or evening pills for 7 days. Then ignore day 1 and average the rest. That average is far more telling than any single reading. Third, standing measurements are crucial. On 2 or 3 of those days, check pressure sitting. Then stand up carefully, wait 1 minute, and check again while standing. If possible, check again at 3 minutes standing. If the top number drops by 20 points or more, for example from 130 to 108, especially if dizziness or grey vision occurs, that is a major warning sign. After a week, 3 zones generally appear in home readings. A too high zone, systolic regularly at 140 or above, or diastolic 90 or above. This is clearly dangerous long-term, especially with diabetes, kidney disease, or past stroke. A safe green zone for many, though not all, seniors, systolic mostly in the 120s to low 130s, diastolic in the 70s to low 80s, with no dizziness or falls. A too low or fragile zone, systolic under about 110-115 at home, especially if lightheadedness or near fainting appears, or a large drop of 20 or more points on standing, or diastolic in the 50s in frail seniors. For many robust older adults in their 60s or early 70s with high risk factors, a home systolic in the 120s is an excellent target. For many frail seniors in their late 70s and 80s on several medications, a home systolic in the 130s and sometimes even the low 140s may be a safer compromise, as long as it is not higher and morning surges are controlled. Once a week of readings is collected, seniors can bring the log to a clinician and change the conversation. Instead of asking, "Is today's number okay?" the question becomes, "Here is what pressure looks like all week, sitting and standing. Where should this body land?" A 69-year-old with diabetes and a previous small stroke, with a home average of 142 over 86 and no dizziness, may be guided toward the 120s or low 130s by adjusting medications upward carefully. An 84-year-old on 3 blood pressure pills, with a home sitting average of 118 over 68 and standing readings around 96 over 58 with dizziness, may be guided towards slightly higher numbers, perhaps sitting in the 130s and standing safely above 110 by reducing or timing medications differently. Medication changes must always be made with the prescribing clinician. Seniors should never change blood pressure doses alone based on a home reading or a video. With the log in hand, clinicians can consider reducing doses if pressure is too low or standing drops are large. Using more gentle combinations of pills that smooth pressure over 24 hours instead of causing big swings. Adjusting timing, such as moving a dose from bedtime to morning or vice versa. Lifestyle also matters. Dehydration exaggerates drops on standing. Unless there are strict fluid limits for heart failure or kidney issues, many older adults feel better with around 6-8 cups of fluid daily. Too much salt pushes pressure up. Too little, in some frail seniors on diuretics, can worsen low pressure and falls. The right amount must be tailored. Alcohol in the evening can cause sudden dips in pressure, especially when combined with medications, raising nighttime fall risk. Large, heavy meals steal blood for digestion and can cause after-meal dips. Smaller, more frequent meals can help. Simple habits like sitting on the edge of the bed for a minute before standing and using a cane or walker when balance feels uncertain give body systems time to adjust and prevent sudden collapses. A few questions arise often. Is lower always better for pressure? In younger adults, lower within reason is often better. In frail seniors, pushing below certain thresholds, often around 110 systolic, particularly with big drops on standing, can cause fainting, falls, and poor brain blood flow. The risk curve is not a straight line, it forms a U. Does this mean seniors should now aim for 140 instead of 120? Not automatically. Many older adults, especially in their 60s and early 70s, clearly benefit from home pressures in the 120s or low 130s. The question is always whether getting there produces symptoms or dangerous drops. What if the office reading is high but home readings are fine? That is common white coat effect. Treatment decisions in that case should rely more on home averages or a 24-hour monitor than on a single office spike. What if the office reading looks lovely but home readings are high? That is even more concerning. It means that high-risk pressures are occurring at home out of sight. A home average in the 140s or above deserves attention even if the clinic number looks excellent. If pressure is low at home and dizziness appears, should a dose be skipped? Skipping or halving pills alone is dangerous. Sudden changes can cause rebound high pressure or rhythm problems. The right step is to call the clinician, describe the readings and symptoms, and let them guide the adjustment. To see how this works in real life, consider George. George was 77, a retired mechanic. He had long-standing high blood pressure, type 2 diabetes, and mild heart failure. For years, clinic readings were in the 145/155 over 80/88 range on 2 medications. After hearing about newer guidelines, his cardiologist decided to aim lower, toward 120. Over several months, an extra pill was added, then doses were gradually increased. At the next visit, office blood pressure was 122/68. Excellent, the cardiologist said. Under 130, this is exactly where we want it. George felt proud of that number. But at home, he began noticing changes. Getting out of bed, he felt woozy. One morning, he nearly fell in the bathroom. His wife heard new complaints. My head feels empty when I stand. My legs feel like jelly. His daughter, a nurse, bought a home monitor and insisted on checking both sitting and standing. Over a week, the pattern looked like this. Morning sitting, 118/124/68/72. 1 minute after standing, 95/100/55/60 with clear dizziness. Evening sitting, 112/118/64/70. Standing, 88/96/52/58, sometimes with near fainting. Twice, the standing reading was 86/50, and George had to sit immediately. They brought the log to his next appointment. "Doctor, the office number looks great," his daughter said. "But here is what happens when he stands." The cardiologist studied the readings. "These drops are too big," he said. For George, 120 sitting is not safe if he is dropping into the 90s when he stands. They made changes. One blood pressure medication was reduced by half. His diuretic was moved to earlier in the day to avoid nighttime dips. Hydration and slow rising from bed and chairs were emphasized. A month later, new readings showed morning sitting 130/136/74/20/78, standing 118/124/68/72 with no dizziness. George felt steadier. The near fainting stopped. He walked more confidently, resumed short walks outside, and did light chair exercises. 6 months later, the cardiologist reviewed. No falls, no hospital stays, home average systolic in the low to mid 130s, kidney and heart failure status stable or slightly improved. For this body, the 130s are the sweet spot, the cardiologist said. Trying to force numbers into the 120s was harming function more than helping the heart. George still had a reading higher than the perfect 120/80 poster. But he was safer, more stable, and more independent. That is the ultimate goal, not a pretty number on paper. A functioning brain, a safe gait, and a life lived outside the hospital. Patricia's story returns at the end of this discussion. An 81-year-old who did exactly as instructed, swallowed every pill and cheered when told 118/70 perfect. No one checked her pressure standing. No one asked if she was feeling unsteady. That perfect number may have starved her brain of blood when she stood, led to a faint, a fall, a hip fracture, and a brain bleed. Those outcomes were not an automatic result of turning 81. They were in part the consequence of chasing the wrong number in the wrong body. Seniors who have listened this far now hold knowledge Patricia never received. There is a clear understanding that 120/80 is not automatically the best target for every older adult. There is an appreciation of how aging arteries, slower pressure reflexes, multiple medicines, and frailty change what good control really means. There is a simple way to check pressure at home. sitting and standing, to spot dangerous drops that can lead to falls and head injuries. There is a framework for asking clinicians about a personal safe range, instead of quietly accepting a one-size-fits-all number. Information like this turns passive trust into informed partnership. But information only protects health when it leads to action. Seniors can obtain or dust off a good home blood pressure monitor. Spend 1 week checking and writing down morning and evening readings, sitting and standing. Bring that log to the next appointment and ask, given age, strength and medications, what should the safe range be? Speak up about dizziness, near fainting or falls instead of dismissing them as just old age. Every stroke prevented, every hip fracture avoided, every extra year of independent living begins with that sort of attention. Before this video closes, 2 simple requests. First, seniors who appreciate clear, direct explanations about heart health, blood pressure, atrial fibrillation, and medications tailored to adults over 60 can subscribe so future episodes are not missed. Second, sharing this video can be powerful. Think of spouses, friends at church, neighbors in their 60s, 70s and 80s who proudly say, blood pressure is 120/80, but quietly feel dizzy, weak or unsteady. This might be the message that keeps one of them on their feet. In the comments, seniors can choose one of 3 phrases about their situation. Too low, if home readings are often under 110 systolic, or if dizziness or near fainting happens on standing. In range, if home readings are mostly in the 120s, 130s with no dizziness or falls. Talking to doctor, if home readings are often in the 140s or higher, or if numbers are low but symptoms are present. Those 3 options can mark the first step toward a safer, smarter relationship with blood pressure, one that respects numbers, but never lets a single perfect number overrule common sense or how a senior actually feels. Disclaimer: the content in this video is for educational purposes only and is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician regarding your medical condition. Never change your medication dosage without consulting your doctor.